So today's topic, I'll be focusing only on the central line or the venous access, the access port infection prevention bundle. There are many other aspects of infection that can occur in dialysis patients because so many fluids come in contact with patients' blood circulation as well as the machine and the instruments and so on. But my focus will be on the catheter-related infection, and maybe I'll touch also upon the access site infections in AV fistula patients. So to the participant, I'll just put this as a self-check so we can address all this at the end of the session. You can answer yourself what you do in your dialysis unit. So what is the most common site of initial HD catheter insertion in your dialysis unit? What skin disinfection preparation do you use for insertion of HD catheter? Do you use full body drape for HD catheter insertion? Do you use chlorhexidine containing dressing for the HD catheter site? Do you follow hub the rub before access? Do you use disinfectant cap when a port is not used? So let us take one by one in the next few minutes. So this is a very beautiful CDC checklist, and it mentions the core interventions of dialysis in preventing dialysis associated bloodstream infection. So what are the core intervention is? The first thing is you should have an ongoing surveillance and feedback. This is very, very important because then only you will know that whether your preventive bundles and your performance is up to the mark. And also you will pick up outbreak at the earliest. And you can even benchmark whether you're performing better than the previous year. So this is very, very important. Surveillance and feedback to the unit is very important. So this is usually done by an infection control unit if you have in your hospital, or it can be done by a dialysis. If you have an independent dialysis unit running without a hospital with infection control, with the dialysis unit, the leadership should be supervising that, the nursing leader or the technical person leader. So usually the audit are done by infection control because of the bias involved, but this is important that surveillance should be ongoing and monthly surveillance data should be shared with the unit to know how they have performed. Hand hygiene observations is also very, very important. So an audit and feedback is very, very important, and it is a core intervention of a preventive, CLABSI preventive bundle in dialysis facility. Then the catheter vascular access care observations that has to be audited, which I'll be discussing. Staff education on competency should be checked at the entry as well as annually or whenever it's needed. And if there are a large amount of recruitment happening, then also you need a training program. So training and retraining is very important, as well as you have to check the competency. Patient education and engagement is also one of the core engagement. Please remember that patient arrives and be with you for only maybe every third day or so for 3 to 4 hours, but the rest of the time patient is at home with a catheter. So unless he knows everything about how to care the catheter to prevent infection and to report at the earliest sign of infection, that's also important. So you have to address that, and there should be educative material or videos that should be given to the patient. And catheter reduction is another important thing. So by this, we mean that the temporary catheter reduction should be attempted for each patient, and overall, most of the patients should be having AV fistula or thermocap. Chlorhexidine for skin antisepsis is very important. So you should be knowing what percentage of chlorhexidine are using for skin antisepsis in your center and whether you need a practice change. Catheter hub disinfection, again, it's very, very important for each axis. And antimicrobial ointment, which is unique to HD catheter, which is not part of other CLABSI bundle that we use, like CVC bundle care that we use in the ICUs. We don't mention about antimicrobial ointment, but for HD catheter, and antimicrobial ointment is one of the preventive bundle. So let us deal with this, see one by one. So if you know these 9 aspects, and if you can self-check with your unit whether most of this are done or all of this done, then I think you're doing well. Otherwise, we can address those gaps and initiate these things in your center. So the thing that I'll be focusing today will be catheter vascular access care observations mostly. And some of the aspects of chlorhexidine skin antisepsis, catheter hub dysfunction, and antimicrobial amendment. So, so if what by you all be very well aware of how an access port is disinfected and handling. So our focus today will be on these aspects, because this is one aspect where most of the technician or the nurses who are handling the dialysis catheter are not aware or not fully aware or can compromise. And that is the most important step called the carrying of the hub, which is not used for the last 2 or 3 days because the patient is at home coming for the dialysis first time. So this is what we call the hub, and there is a cap, you see. And what are the things that should be done before accessing the hub is what is the most important change that recently has been introduced, and ensure that it is followed adequately. So let us see what happens when you do the hub care. So briefly, vascular access for hemodialysis can be through AV fistula or AV graft. Fistula is a type of access that is a preferred access for chronic hemodialysis, and it is a surgical anastomosis between an artery and a vein that allows arterial blood to flow through the vein. You can also use graft in a patient requiring chronic access doesn't have adequate vessels, and it is a biologic or semi-biologic or a prosthetic graft, and that may be implanted subcutaneously, and it's used to create an anastomosis between the artery and the vein. So complication can result due to infection, and this can be more severe than a fistula infection getting infected, because the risk of disintegration of the graft materials and subsequent hemorrhage is high. So CTC recommends AV fistula be created and used for long-term hemodialysis treatment because of the lower incidence of infection. It has the least infection as compared to other modes. AV graft is the next preferred type of access, and for acute hemodialysis where the access is for less than 3 weeks duration, and the vascular access that may be obtained using a non-cuffed or a cuffed catheter. And if a catheter must be used for access more than 3 weeks, a tunneled or a cupped venous catheter is recommended. So these are the options. The best will be AV fistula because it's least risk of infection. Second will be AV graft, which is not usually that commonly done. Then comes acute HD, that is patient coming with an acute kidney injury. You will use a non-tunneled catheter, a short-term central catheter. And if the patient needs long-term access of more than 3 weeks, what is preferred is a permacath or a tunneled venous catheter, because that has less risk of infection as compared to non-tunneled catheters. So temporary vascular access can be put in subclavian, jugular, or femoral vein catheters. And the risk of infection varies according to the type of device, the location, and the method or the technique of placement, and your practices both in insertion and maintenance. So the location, upper extremity, is always less risk of infection than a femoral catheter. And the method or technique of placement, like cut-down or tunneled or percutaneous, is better than non-tunneled catheter, which is used short-term usually. The tunneled catheter can be used for many months to years. Then comes the most important thing, that is the infection prevention practices, including insertion and maintenance. And each time you access the port, the hub, what all do you do? Those are the important things that you have to keep in mind. And if you have a catheter with large number of ports, then again the risk of infection is less. So percutaneously insert non-cupped CVC has been observed with the highest rates of bacteremia in the hemodialysis setting, and more so if it is femoral. So make sure that if it is an elective HD catheter insertion, femoral catheter is avoided unless you have no choice. So, so most often, what is the catheter that is used is jugular, and subclavian is usually preserved for permacath because you need that line. So you don't want for short-term catheter to use subclavian because it can get thrombosed, and then the patient will not have an access for long-term catheter if that is thrombosed. So the potential routes of infection can be due to several mechanisms. It can be due to contamination of catheter hub. It's a very common thing that we find, though we don't usually look for culture from the hub, but then it is a potential source which is proven beyond doubt. And so how the hub gets colonized and gets infected is like extrinsic sources, most commonly healthcare worker who doesn't perform hand hygiene in the appropriate way, and then the hub gets colonized, and later it can get into the catheter and goes into the blood, causing bacteremia. It can be endogenous from the patient's skin who gets colonized with bacteria. So it's very important that those patients who are in the hospital undergoes chlorhexidine bath to decolonize. If they are at home, we will advise to have a bath and keep the port side clean and use soap and water to clean. So without dampening the dressing. But if the patient is in the hospital, it's very important that we decolonize the patient, especially ICU patient, with chlorhexidine to reduce the bioburden and reduce the colonization around the catheter. So the catheter can also be contaminated by a contaminant infusant, which can be in the fluid that you give, or it can be into any of the medication that you use. And the medication can be infected, or when you when it is administered due to improper asepsis, asepsis not being followed, the nurse can contaminate the infusate, and that is another source. So the most important thing is the hub care and the hand hygiene, which will actually be a major practice change that can be easily done to prevent catheter-related infection. The skin organism that may colonize in the patient, that is what we talk about, in the patient getting colonized, and this is taken care of by decolonization method, that is usually a chlorhexidine bath or the wipe, and at home patient can very well take bath. Then again, the contamination of the device can occur at the time of insertion if you don't follow the insertion bundle, which usually is done by the doctors. So I'm not focusing too much on the insertion bundle, because after that, the maintenance bundle is usually taken care by the technicians or the nursing personnel who is taking care of the patient. The risk of infection is multiplied by the host risk factors and several other factors. Host is as the dialysis patient are mostly diabetic. They have renal disease. They are also critically ill most of the times. They are at highest risk of infection because of per se the underlying multiple problems, medical condition. They also have low albumin. All this increase the risk of infection. And dialysis also increase patient risk of infection because the direct access to a normally sterile site, which means the bloodstream, and also in peritoneal cavity if the peritoneum is the access for the dialysis. And most common types of dialysis with infection include access site infection, bacteremia, and if it is peritoneal mode, then peritonitis. Also remember, there are a lot of non-infectious origin of cause of fever, and these are called as pyrogenic reaction, allergic reactions, or chemical reaction, which may be related to the dialysis solution that is being used, and the endotoxins. And you may not culture anything in these patients. So that's an important differential diagnosis, and that is a huge challenge because you may or may not wait for the culture, but if the patient presents with chills, you are bound to take culture and start empiric antibiotic therapy, and you may stop later on. So this is an important differential diagnosis and very difficult to differentiate in the acute phase. Okay, so again, reiterating what is the CD says, the preferred insertion site is the right internal jugular if it is short term, because you may have to preserve the subclavian axis when there is no jugular options available, and those patients who are not anticipated to need a permanent vascular access because the thrombosis and stenosis may result in later subclavian vein getting blocked, and you may lose that access for the patient for long-term dialysis. Okay, now coming to the access site care. At insertion, what you do is 2% chlorhexidine is the antiseptic of choice for the skin care, and it should be applied in rubbing motion for 1 minute. And then it should be applied in outward circular motion, and then allow to dry before cannulation, because you want that chlorhexidine to act and disinfect and clear the bioburden or the microbiome that is in the skin site. And the insertion site should not be palpated once a site has been prepared. Asepsis should be maintained throughout the insertion. And most importantly, which we rarely fully fulfill or follow, is the PPE. What the CDC advises, sterile gown and apron definitely you may be wearing, but in addition you have to wear mask and cap, because you may shed the bacteria from the nose into the access site, and this can result in staph aureus or other pathogen the healthcare is colonized with dropping on the access site. And so you have to take all the precaution, like in OT. When you access the site at insertion or maintenance, mask and cap is a must. And many may have respiratory infection, mild infection, which may ignore, and they may not report. So they are the more shedders. They shed maximum bacteria, and the access site or the catheter insertion site get colonized with the bacteria, and later on they can develop access site infection. So this has to be also kept in mind. Then coming to maintenance. So again, going back, make sure that you are using 2% chlorhexidine for the skin antisepsis, because many hospital may be following povidone iodine, which is inferior to chlorhexidine, as proven in many studies. If you have allergy, if the patient has allergy to chlorhexidine, again, they can opt for povidone iodine. Then coming to access site maintenance. When a CVC is used for vascular access, the standard practice to clean the exit site and redress the site for each dialysis treatment. The dressing should be replaced when it becomes damp, loose, or soiled, or when inspection of the site is necessary. CDC also states that the gauze dressing should be replaced every 2 days, and the transparent dressing at least every 7 days on short-term catheters. But in dialysis, it may be totally different, because at each axis, you will be changing the dressing. If the dressing cannot be used, chlorhexidine dressing cannot be used, then you can use povidone iodine at the access site. So what CDC recommends is you have a patch containing chlorhexidine, which is ready-made patch. If the patient can afford, that will be the best thing, but it may be costing 500 rupees or so for that patch. And that can release chlorhexidine all the time, and the risk of infection is less. If the patient cannot afford, then the alternate will be a chlorhexidine dressing. All personnel involved in the patient and staff members should be wearing masks when they access the connections, because they can shed bacteria onto the site. Then comes the maintenance bundle. Most important thing is a catheter hub care. So the studies have shown that there is 4-fold decrease in the rate of CLABSI in HD by individually wrapping the catheter hubs with gauze soaked in povidone iodine for 5 minutes prior to the removal of the caps. You know, if you have caps, even the caps is exposed to the outside environment, and colonization can happen in the caps. So if a person, the the person who is accessing the hub is using a sterile gloves and then touching the cap, which can be colonized, then the further act is not, he's not following any asepsis, because his sterile gloves is already contaminated. So what CDC recommends is individually wrapping the catheter hubs with gauze soaked in povidone iodine for 5 minutes prior to removal of the cap. Having the nurse patient, both nurse and patient, wear mask when you access the port, donning a fresh pair of gloves for each catheter cap removal, because it is a sterile board that you have to access the cap as well as the port. Wiping the surface that had not been covered with cap with povidone iodine pledget, and immediately connecting the catheter hubs to connection without leaving it free or open, dangling. So most important thing that I want to stress today is care of the catheter head. That's the most important thing that will change your CLABSI rate. Because a patient, they are accessed once in 2 or 3 days or 4 days, the colonization happens most at the hub, and that is in direct contact with the blood and the connector. So I think if you give maximum care to that, I think, and it is not a big thing, it is easy, only the practice change and consistency and compliance. you can definitely drastically reduce the CLAPSI in your dialysis unit. Then we definitely have to talk about personal hygiene to the patient. Patient should be educated with videos. Don't give handouts, because seeing is they can understand better. All patients should be taught to wash their access if it AV fistula with soap and water daily and before hemodialysis. So they reduce the bioburden. Patient should be instructed to keep the central venous catheter dressing clean and dry if they're using a HD catheter. Patient should also be instructed to ensure that all the staff accessing the access site are preparing the skin appropriately prior to cannulation, that is using 2% chlorhexidine and in a proper way, plus wearing a mask for all the access connection. They should be taught to recognize, the patient should be taught to recognize signs and symptoms of infection, so they report at the earliest. So in Western countries, the patient, you can imagine the patient should also be instructed, so they monitor the staff. So that is the privilege that is given to the patient, that they they have the ownership of taking care of themselves, so they can actually stop the staff from doing that. So we don't have patients like this in India. So we have to take the extra caution. They may not even stop us even if we miss a step. But then CDC goes one step beyond and tell that the patient should be instructed to ensure that all staff accessing their access site, so that they prepare the skin appropriately for cannulation and wear the mask for all connections, because there can be a gap in the compliance. So if the patient is made the owner of their problem and their access site and the cannula, the compliance may improve, and that ultimately what they want is reduction in the CLAPSI, because ultimately is the patient who suffers. So some educated patient may be knowing all this. So it is more important that in this day and age that we practice all the asepsis practice for the CLAPSI bundle, and especially during the maintenance bundle. So this is an old CLAPSI 2014 prevention bundle that was put forward in CDC. And recently we have a change in this by multiple group coming together, and they put forward a beautiful compendium, that is CLAPSI prevention bundle update. And SHE, IDSA, APIC, Joint Commission, JCI, CDC, everything, Surgical Infection Society, everything have come together, and they put a beautiful document called the CLAPSI compendium. And there are other guidelines also that they have put forward. So this was recently updated, and this is in 2022. And this actually have put forward some changes from the previous. So this has essentially 4 headings. What is called the essential practice should be adopted by all. Additional approach is that if your CLAPSI rate is still high after practicing all the CLAPS essential practices, then you introduce additional approaches. And there are approaches that are mentioned should not be considered as part of routine CLAPSI prevention. And for some, we don't have enough evidence, and this is called unresolved issues. So it's important that you have your surveillance data. Then only you will know when to introduce additional improves. So this brings to the point that every unit should have a dialysis reporting format in the monthly reporting format. And I will just touch upon, because I'm not going to talk about surveillance today, but I will explain to you at the last what, if you're following, it's very, very good. Otherwise, you should be following. Then only you know whether your essential practices up to the mark, why your infection rate is high, and whether you have to introduce additional approach, because each additional approach may have some cost tagged with that. So you don't want to put a cost for the patient, because this is a recurring payment. So essential practices, it's just again a revision, but it's important that I reiterate. Essential practices is for CVC, including HD catheter. So before insertion, you should look at whether this is necessary and whether what would be the best for the patient, whether short-term or long-term CVC placement. And whoever is inserting, usually it is a doctor, so they should have education and competency, and they should be actually privileged to insert, because infection can happen at insertion also. And those who are giving a maintenance care during catheter dialysis, they also should be actually trained and their competency should be assessed and they should be privileged. This is very, very important. You can use simulation training for catheter insertion and maintenance, and this is very important. It has helped many, and this is getting very, very popular than any other mode. You can educate through videos and so on, but simulation training is a must, which is a mode of a skill training that should be mandatory for all dialysis technicians. Bathe the ICU patient. If the patient is in ICU with chlorhexidine preparation, they should have a daily bath. As this again reiterating because I've told before. And if the patient is non-ICU, that is, you can imagine a patient coming as outpatient dialysis, bathing daily is important. And if they have AV fistula, they should have they should have washed with soap and water before they come for the dialysis. So what else will you look at insertion? We should have a process checklist. So if you have an classic prevention starts from insertion. So you should have a checklist for insertion bundle. And when the doctor is inserting, the lead nurse should have a bundle and check that everything is followed to the dot. And the lead nurse can even stop the doctor if there is any breach in asepsis during any time of the process, like breach in touching after touching a non-sterile item and bringing that back to the sterile item. And perform hand hygiene prior to catheter insertion or manipulation. The subclavian site is preferred to reduce infection complication when the catheter is placed in ICU setting, except in those requiring or will require hemodialysis because of the risk of stenosis. And whenever you use a HD catheter, it should be an all-inclusive catheter carter kit so that you don't run around to bring in some new items. Use ultrasound guidance for catheter insertion, but still you have to follow all the sterile precaution. The ultrasound probe should be covered with a sterile sheath. Use maximum sterile barrier precaution. That means you should have a full body drape. You should not have a drape that is covering the neck. If you have a full body drape, then your risk of getting infection because of contamination of a sterile item is less. Then chlorhexidine antisepsis should be at least 2%. You should not be using 0.5%, which is used for hand rub. It should be at least 2%. Or you can check what is used for hand rub in the OT, bring the same thing that is must for skin antisepsis at the time of insertion. After insertion, appropriate nurse to patient ratio is important. That is usually for ICUs, not talking about the dialysis. Use chlorhexidine containing dressings for CVC in patients more than 2 months of age. Again, that's the best thing. If the patient cannot afford on a chlorhexidine dressing, twice they have to change in a week and causes a problem, then you have to think of other option of chlorhexidine impregnated dressing. So non-tunnel CVC, yes, I have told about the dressing change for dialysis. It may be for each dialysis access. The most important thing that I spoke today was disinfection of catheter hubs. Even if it is needleless connectors, it should be disinfected with chlorhexidine before you inject anything or connect anything. And how long should you disinfect the catheter hubs? Minimum is 5 seconds, at least 10 rubs. Alcoholic chlorhexidine preparation containing more than 70% alcohol should be used. Remove all non-essential catheters that as appropriate when there is no more dialysis required. Routine replacement of administration set is not required if the patient is in ICU, but this is again for dialysis catheter. None of this will be used to the dialysis catheter. And surveillance is very important. So this is what I was talking about. Most of you will be familiar with. This is called chlorhexidine impregnated sponges, and this is usually actually release the chlorhexidine continuously. So the colonization at the catheter insertion site is very, very less, and it is proven that it reduces catheter-related bloodstream infection. Especially, you should consider this for at least ICU patients. So if your dialysis infections is not controlled by the core prevention elements that I discussed, then you can consider additional approach. What are they? You can use antiseptic or antimicrobial impregnated CVC. Again, dialysis catheter are also available, but it's expensive. Use antimicrobial lock therapy for long-term CVC if you have recurrent dialysis infection, HD catheter-related infection, and the patient cannot have another access, all are thrombosed or used, and that is a lifeline, then you can consider antimicrobial lock therapy. But again, in Indian scenario, we have a huge challenge because of drug resistance. The usual antibiotic that is used is minocycline, but there are other options. And you can also use other antibiotic that to lock the catheter, and that depends on what is the bug that usually recover. It can be gentamicin or vancomycin. And there is a protocol for that, how much to use depending on the catheter length and so on. The use of recombinant tissue plasminogen activator once weekly has been tried. Again, it reduces the biofilm effect and reduces the risk of colonization and infection. Then use antimicrobial ointment for HD catheter insertion. Again, it is the quality of evidence is high. That can be easily tried as an additional approach. Use antiseptic containing hub or connector cap or a port protector to cover the connector. This is again an additional approach, but this has helped because I have first-hand experience of using this in our ICU when we had an outbreak and we couldn't control with a usual approach. So let us take a look at what is this. There's something called antibiotic impregnated. I'll just talk about this first. That is antibiotic impregnated CVC and antibiotic lock therapy. Patient with long-term hemodialysis catheter who have history of recurrent CLABSI, and prophylaxis for patient with limited venous access and a history of recurrent CLABSI. In all these patients who are highest risk of sequelae of CLABSI, like they have a cardiac device which can get infected and can lead to endocarditis or a lead related infection. All those patients you can think about antibiotic impregnated catheters or antibiotic lock therapy. The other additional approach that I was talking about is the catheter antiseptic impregnated catheter hub. So there are a lot of evidence gaining for this antiseptic containing caps, but this is still an additional approach because it is little costly. So we cannot overcome this by just putting this. But then if your hub the cap technique is not good, compliance is poor, you have given multiple training, you can consider what is this called the antiseptic impregnated hub. So it comes with a filled, that is lined with the alcohol and chlorhexidine hub, and it is available as a strip of this thing. So each time you open, it is a new one, and you can use this. So if the patient after dialysis, if you use this hub and he goes home, then that hub is protected, and there is also continuous release of alcohol and chlorhexidine, and then the risk of catheter hub colonization and infection is less. So next time when the patient comes for dialysis, you have to actually impregnate a povidone containing gauze over the hub, because the hub outside will be colonized. And then after a few minutes, you remove that, and then with a sterile precaution, open the hub and you can start using the port. So this has not replaced the essential practice, which is still the manual disinfection using alcohol swabs, and then you use the hub the rub technique for minimum of 5 seconds and clean the hub before you access or administer anything through the hub. This is the most important message that I want to get across. So what are the approaches that should not be considered as a routine part of CLABSI prevention is, do not use antimicrobial prophylaxis for short-term or long-term catheter because the catheter is there. You should not be giving antibiotics. And unresolved issues, there are so many things that is again still controversial, which I'm not going to talk about because of less importance for dialysis patients. Apart from this, there are a lot of independent risk factors which some can be reversed, some cannot be corrected. The problem with increased risk of CLABSI is certain patients who are in the hospital for long, who are neutropenic, who are obese, who have extremes of age, who are on parenteral nutrition, transfusion of blood products. All this can happen, and these patients increase the risk of CLABSI, and this patient can have additional lines in addition to the HD catheter. They can have central line also. So we won't know which catheter is causing the bacteremia. So, but there are some things that I have highlighted in the blue that are correctable factors, which we can definitely look at. One is the need for the HD catheter should be assessed if it is introduced for a critically ill patient for a short term, and there should be a daily checklist for catheter duration. I'm not talking about maintenance dialysis, but for critically ill patient. And how to prevent heavy microbial colonization at the insertion site, I have spoken about by chlorhexidine bath and chlorhexidine impregnated sponges at the catheter insertion site. How to reduce the microbial colonization of the catheter hub by hub the rub technique. If you still cannot bring down the infection rate, you can switch to antiseptic disinfectant, that is impregnated disinfectant hubs. Then you can avoid multi-lumen catheters because more the lumen, more the chance of infection. You can avoid concurrent catheters. That's what I'm talking. Patient can have a central line, can have a line, can have a HD catheter all in one go. But if you can make assessment daily and reduce the number of catheters, again, you can bring down the CLABSI rate. Reduce number of nurse to patient ratio always is a challenge in Indian scenario. Again, if your nurse patient ratio is big, the more number of patients have to be taken by a single nurse, your infection prevention practices will come down. So that's a challenge. But still, the basic maintenance bundle should be followed for any catheter access that is done. Then, if you use a substandard catheter care, excessive manipulation, often touched and lying around without a cover, all this will increase your risk factors for CLABSI. So all these are modifiable and should be practiced and followed to reduce at every patient and catheter access. Then coming to a checklist, which you can have, hemodialysis catheter connection. So this can be a checklist and can be audited in your center. How compliant are you? So if a trainee or you are giving a training to a new people who have come to your dialysis unit, you can have this checklist. Wear mask at the access time. Yes. If they are wearing, even if it's chin down during access, they have to wear the mask so that they don't shed the bacteria. Perform hand hygiene. Put new clean gloves for each access. Clamp the catheter and remove the caps. Scrub the catheter hub with antiseptic agent. Allow the hub antiseptic agent to dry before you give any infusion. Catheter, connect catheter to blood lines aseptically. Remove gloves and perform hygiene. This has to be done for each access. Then when you disconnect also, the same thing are repeated. One is you have to wear mask, perform hand hygiene, put new clean gloves, clamp the catheter. If you are wearing a clean gloves also, if it's not a sterile glove, you have to use hand rub, clamp the catheter. And disconnect the catheter for blood lines, scrub the catheter cap with antiseptic agent, allow the catheter hub agent to dry, antiseptic agent to dry, attach new caps aseptically. So if you are using disinfectant caps, it will come as a new one. But if you are reusing dipping in the disinfectant, then you have to put in the cap immediately and it is be done aseptically and remove the gloves and perform hand hygiene before you give cap for the next patient. So this checklist can be done to audit your practices. And this is another checklist that again can be used as an audit tool, that is for catheter connection and disconnection observations. And this can be given as a feedback to the unit. So you can document how many procedures you have observed, whether mask is worn properly, hand hygiene. This is how you can have an Excel sheet or a chart, and then you can tick accordingly. So prevention of catheter-related infection, this is an again flow chart. So there are something called intraluminal prevention of CVC infection and extraluminal, nothing but how different factors can play. So intraluminal is, you can look at the non-pharmacological intervention in preventing the CVC. So you always consider closed system and do not disconnect devices unless it is necessary. And consider select use of specific antibiotic locks if it's in a high-risk patient. If you have multiple recurrence of CLABSI and you want that line to be retained, and then consider elective use of specific antimalarial lock if high-risk patients. Yes. Yeah, and you can even consider the thrombolytic agents if it is a recurring event. So this is advice for those with multiple prior catheter-related bloodstream infection, which is spoken as an additional method. And if you have a high rates of RAPSI, which is described in the unit as 3.5 per 1,000 days, you can have your own benchmark and you can try to achieve better. So these are measures which you are taking care by preventing intraluminal in prevention of infection. That means you are doing something into the lumen, injecting something to the lumen to reduce the infection rate. And these are not the usual method. These are additional approach when your unit CLABSI rates are high. You can also bring in some extraluminal prevention for CVC infection. And again, what you can do is hand hygiene. You can give a feedback and try to improve a hand hygiene technique and catheter care protocol. Whether they are performing the correct hub care and other things that can be monitored, and change the CVC with they should have this is not practice for the outpatient, only for the inpatients. If there is a protocol to usually we don't advise catheter change every week or so unless the catheter is no more used. That is an indication for removing of central line, and these are the additional prevention methods. Again, you can this is the thing that can be shared with patient when you educate the patient what is the do's and don'ts. Again, you will all be having this. If there is anything missing that you want to add, you can add looking at this. Wash the skin over the axis with soap and water every day if it is a fistula. Conduct your daily routine 1-minute axis check, whether it is clean, whether it's signs of infection or redness or pain. Tell your care team if you see any bruise or change in color. And rotate the needle stick for each treatment, each time you access. What you should not, a patient should not be doing is wearing a tight-fitting clothing or jewelry, carry heavy objects in the arm, and have blood drawn or blood pressure checks in that, and scratch or prick. That should all be avoided. So with that, I will end, and we will again answer some of these questions that are put forward in the first instance. One is the most common initial site of HE catheter insertion should ideally be, if it is a short term, it should be a jugular access, and avoid femoral access as much as possible because the infection risk is less with the upper body insertion. If the patient is not expecting a long-term catheter, then subclavian could be an option. What skin disinfection preparation do you use for insertion of HG catheter? The appropriate skin disinfection is 2% chlorhexidine at insertion. Chlorhexidine plus alcohol, 70% alcohol. Do you use full body drape for HD catheter? You should be using. You should not be using a small drape which covers only the neck and shoulder. It should be a full body drape. Do you use chlorhexidine containing dressing for the HD catheter site? Yes, ideally it should be, if even though it is changed twice weekly. Do you follow hub the rub before the access? The most important thing that can reduce infection if you look at it critically. Perform hub the rub. Still, if your catheter rate, infection rates are high, you can think about switching to disinfectant caps. Do you use a disinfectant cap and port is not used? This is an additional approach which you can think if your rate of infection is high. So surveillance, I'm not going to talk because I'm focusing more on prevention aspect. But if you are doing a surveillance, there are easy, simple method is your denominator is first 2 days of the dialysis number of patients that come. It's a denominator, and your rates are reported based on whether it is a fistula infection, whether it is a HT or a permanent cath. You can report independently. And there should not be a duplication of the same patient twice. That is why you are taking only the first 2 days of the month, whoever has undergone dialysis at the denominator. So if you are monitoring this on a monthly basis and you can look at the trend and know when there is an increase in infection, then you have to know then there is a problem, and you can audit all the things that I have told. Process audit, how the healthcare performer is doing at the insertion and maintenance, all this can be audited, and you can give a feedback. With that, I think